Hi everyone, this is Mr Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. This is of a patient who attended with an infected left ear, and what was of primary concern for the patient was that they had previously undergone a surgical procedure in their left ear, quite a few months ago now, I would say approaching a year possibly, called a mastoidectomy. And when patients have a mastoidectomy, they do have to have their ears examined on a regular basis. And quite often when patients have a mastoidectomy, the skin that lines the ear canal is no longer able to naturally shed and migrate itself out of the ear. So their ears do require regular cleaning. Now, you can see they've got all this damp, dead skin that I'm just peeling away. But at present, I'm not able to see where the active site of the discharge is coming from. But you can see just here where I am now, there's like a bulge of the top part of the ear canal. And as the procedure progresses, when we work towards the roof even more of the ear canal, you'll see that where that bulge is at the top, there's a bit of skin hiding it at the moment. When I peel that skin away, you can see there's fresh blood there and it's weeping. So this soft tissue swelling at the top there, you can see it looks like a balloon. And you can see that skin at the roof. And I do come onto that and remove that skin. It's weeping, it's discharging, and there's also some blood there. So at night when the patient's laying on his left ear in bed, he wakes up in the morning and the pillow case is full of discharge and blood. So the patient's quite concerned. They did actually have an ENT appointment scheduled for the following week, but the patient generally, prior to seeing the ENT, they decided just to come to see myself to have their ears cleaned because they quite enjoyed the endoscopic approach. They also enjoy watching the video afterwards. So although they were due to see ENT to have their ears examined, and typically ENT would remove the debris, the patient, obviously, not only because obviously there is infected, so that need to be treated, but they do come on a regular basis anyway to have their ears suctioned out at the clinic. Now, what this patient previously underwent was a surgical procedure called a mastoidectomy. But before I explain what a mastoidectomy is, I have to explain why the underlying pathology as to which then led to the surgeon performing a mastoidectomy. So this patient, when they attended about a year ago, had what I thought was a cholesteatoma, which can be quite serious, and I proceeded to remove all this dead skin from the top part of their eardrum, after which I referred them to a local ENT surgeon who sent the patient for a CT scan, and the surgeon confirmed the presence of a cholesteatoma, which then led for this patient undergoing the surgical procedure called a mastoidectomy. So let's discuss what a cholesteatoma is. Now, behind the eardrum, we have what we call the middle ear cavity. And the middle ear cavity, it comprises of the inner membrane of the eardrum. So the eardrum comes in three membranes. It also consists of the three middle ear bones, known as the ossicles, and individually they're known as the hammer bone, which medically is called the malleus, the anvil, which medically we call the incus, and the stirrup, which is what we call the stapes. In addition, the middle ear contains a narrow tube, a narrow orifice called the eustachian tube, which connects to the back of the nose, the nasopharynx. Now, ideally, we want the air pressure behind the eardrum to be equal to the air pressure in the ear canal and the surrounding atmosphere. When the air pressure is equal either side of the eardrum, that's when the eardrum is most mobile, it's most compliant, and that's when we hear the best. So it's the function of the eustachian tube to equalize the air pressure. Now, where the eustachian tube connects to the back of the nose, that part is typically shut. But during the course of the day, and involuntarily, without us knowing that we're doing so, when we swallow, yawn or chew, the eustachian tube temporarily opens. The muscles either side contract, and it causes the eustachian tube to open where it connects to the back of the nose. And during this brief moment when the eustachian tube opens, the air pressure can equalize itself. In addition, any fluid that collects behind the eardrum, it can drain out of the middle ear via the eustachian tube when it opens. However, if the eustachian tube gets blocked at the back of the nose, or there's an obstruction there and it no longer opens momentarily when it should, then no air can enter the middle ear cavity, and that creates a vacuum effect, and that then causes the eardrum to get pulled inwards. And typically the eardrum gets pulled inwards in the top region, what we call the attic, and that's because that region of the eardrum is actually just made up of 2 layers, whereas the remainder of the eardrum is made up of 3 layers, so it's thicker. So that top part where it's thinner, it's more prone to getting sucked in. And when that top part of the eardrum gets sucked in, what we call the attic, it creates a little pocket. And that pocket can lead to some serious complications. So our ears, as you can see, they're lined with skin. And this skin, generally, as it dies, it sheds and it moves sideways out of the ear. But if there's a little pocket at the top of the eardrum, the skin can start collecting and forming into a plug within that pocket, and it can't escape. And that skin can then develop into what we call a cholesteatoma. So it's an infected plug of dead skin. And this cholesteatoma can start to grow. And if the eardrum also gets further sucked in, this cholesteatoma starts invading the middle ear space. And in addition, it can start going towards the brain. And in addition to that, at the back of the ear canal, behind the eardrum, so just say we were to go straight through this patient's eardrum and then veer completely to the right, so the behind the back wall of the ear canal where the eardrum is, there's a little entrance there to the mastoid bone. And I'll explain that in more detail, what the mastoid bone is, in a moment. But this cholesteatoma can start growing into that space where the mastoid bone is. And if left untreated, it can be life-threatening, because this infection can then spread to the skull base. It can cause meningitis, a brain abscess, and potentially it can be fatal. So when a patient's got a cholesteatoma, it does need to be dealt with and treated. Now, I'll come back to that in a moment. So I'm just going back to this soft swelling at the top of the ear canal. And as you can see, I'm just peeling away some of this dead skin. And when I do, you can see it's all wet here and there's some bleeding here. So this is the part where the patient needs to really have closely examined by the ENT surgeon. They also, the patient presented with today was some glue ear. So going back to the eustachian tube, so if that eustachian tube doesn't unblock itself, then fluid can't drain behind the middle ear, and the fluid collects and it starts filling up the middle ear cavity, and that fluid eventually gets infected, and we call that glue ear. And similar to a water balloon where there's too much water, eventually that water balloon is going to pop. And similarly, if there's too much fluid in the middle ear, the eardrum can no longer contain all that fluid, and the eardrum will rupture. And this patient today as well actually has glue ear. I can see it behind the eardrum, and you'll see it yourself a bit later on. The eardrum's quite bulged, it's yellow, so this fluid can have that yellowy appearance. So when this patient was diagnosed with a cholesteatoma following a CT scan, the surgeon had to remove it and surgically remove it. So the technique that the surgeon used was by performing a mastoidectomy. And a mastoidectomy is when the mastoid bone, which is the bone behind this ear canal here, so it's at the back of your ear, it's drilled out from the exterior part. So if you just place your finger yourself behind your ear and position it on the flat piece of bone behind your ear, that's the mastoid bone. So what the ear surgeon does, it creates a flap, so it cuts open the skin, and once the skin is elevated, literally drills into that bone behind your ear, all the way adjacent and parallel to the back of the ear canal. And that's because the mastoid bone gives you access to the cavity behind the eardrum, and also with a cholesteatoma, quite often the cholesteatoma can start infecting the mastoid bone itself. As I said, it grows into the cavity. Now, the mastoid bone is air-filled. It's got kind of a honeycomb structure, so it is porous. So if there's any discharge of fluid like glue ear, the mastoid bone can also absorb that. So quite often the mastoid bone is infected, so that needs to be drilled out, all the infected bone. And whilst the surgeon is drilling out the mastoid bone, they can, depending upon the type of mastoidectomy, they can start removing a cholesteatoma if it's growing in the middle ear cavity. And we call that a mastoidectomy. Now, there's two main types of mastoidectomy. One is called a canal wall up, and the other is a canal wall down. So the canal wall up is the more conservative approach, whereby the back of the ear canal, which borders the mastoid bone, it's still kept in its original shape. There's no drilling away of that bone. But in very extreme cases, the ENT surgeon has to actually drill out the back of the ear canal as well, the posterior part, which then means the ear canal, the bone at the back, it's been drilled away. The mastoid bone to the bone behind the ear canal has also been drilled away, and it creates a huge cavity at the back of the ear canal. And we call that a mastoid cavity. So in essence, it enlarges the ear canal by 4 or 5-fold. And that's more of we call that a radical mastoidectomy, or a canal wall down. So the canal wall, the back part of the ear canal, has been knocked down basically. And that's for more extreme cases. And with that kind of approach, the ENT surgeon has more visibility, they have more access within the ear, they can take away, they can ensure that all the infection has been removed. With the canal wall ups, where that, like in this case, where the canal wall is still got it's still in place, it's a bit more difficult for the ENT surgeon to be sure that they've got rid of all the cholesteatoma. So quite often, the patient may have to undergo a second exploratory surgery a year later once everything's healed, just to make sure there's no signs of any cholesteatoma reforming. So they're the two different approaches. Now, when you've had a radical mastoidectomy, and if you watch my YouTube channel, I've cleared quite a few of those out, the ear canal is absolutely humongous, and there's a lot more skin formation because the skin can't migrate out of the mastoid cavity. But this patient hasn't got that. They've got a canal wall up, so the back canal wall is still present. So you can see we're just cleaning all this away. So it's just going to go back into the ear. It's just a bit of residual skin, so I'm just going to peel away as much as I can. So the area of concern for me is kind of around here and a bit higher up. And they also have got glue ear, and you'll see that in a moment. I will kind of highlight that for you when you see it. So the patient, I did advise the patient to bring forward their ENT appointment, which is they had an appointment scheduled the following week, just whenever you got a mastoid, and because of the patient's past ear history, I don't want to have any delays, or rather the patient get treatment ASAP. You've always just got to be really careful when a patient presents with previous mastoid surgery, because you just don't want a reoccurrence of cholesteatoma formation or anything else, because there's not much else to play with. That bone is already kind of, well, this patient's still got a lot of the back part of the ear canal, but the mastoid bone has been drilled away. So there's very little else to drill away behind the ear canal here. And so we just don't want any infection developing behind in the middle ear cavity, going up towards the brain and filling up the mastoid space. So this patient has to have this done on a regular basis. Typically, it's yearly, but with this particular patient, we are seeing them every 6 months. They're just getting a lot of skin formation. They did actually undergo a right mastoidectomy as well after their left ear, and that ear was still healing upon attending. So hoping that was successful, so when they visit the ENT surgeon. So you can see the eardrum there, it's bulged, it's all yellow. You can see the top part of the hammer bone, so that's the fluid, that's the glue. Well, I hope you enjoyed that video, guys, and it just gave you an insight of some of the ear pathologies and the surgical treatments available to help with those. Take care, speak soon.